Hello everybody, welcome. In this lecture, we are going to look at nutrition during periconception. Periconception refers to the time period around conception. It represents a critical period of time when nutritional and other exposures can impact conception, pregnancy maintenance, the growth, development, and the future health of the offspring. Let's look at some key terms related to periconception. Periconceptional period. This is the time period around conception, variously measured in weeks or months, depending on the pregnancy outcomes of interest. Embryo. This refers to the developing organism from conception through 8 weeks. DNA methylation. This is the modification of a replicated strand of DNA by addition of a methyl group to specific regions of the strand. DNA methylation can suppress the activity of certain genes in ways that affect metabolic processes and increase this disease risk. It is, however, a normal part of development and is necessary for cellular differentiation and organ development. However, it can also be influenced by nutritional and other environmental factors. We also have a term neurotube defects or NTDs. This is a group of birth defects that are caused by incomplete development of the brain, the spinal cord, or their protective coverings. And spina bifida is one of the commonest types of neurotube defects. During the periconceptional period, there are a lot of very early pregnancy nutrition exposures, including folate status. Prior to conception, if a woman does not consume enough folate, she is going to have a risk of giving birth to a child that has a neurotube defect, because of the fact that the spinal cord develops during the first 21 days. Iron status prior to conception is also very, very important, because deficiency of iron is also going to impact the health of the unborn baby. Let's look at some periconceptional nutrition exposures that may disrupt fetal growth and development. Weight status. Being underweight increases the risk of maternal complications during pregnancy and also increases the risk of delivery of small and near and early newborns. A child is born very small for gestational age. Obesity also increases the risk of clinical complications during pregnancy and the risk of neurotube defects or excessive body fat. Nutrient status, such as insufficient folate intake. This increases the risk of embryonic development of neurotube, orofacial and heart defects. Excessive vitamin A intake in form of retinol and retinoic acid increases the risk of the fetus developing facial and heart abnormalities. High maternal blood levels of lead also increase the risk of intellectual disability in the offspring. Iron deficiency early in pregnancy increases the risk that children will experience impaired mental and physical development. Iron deficiency. The previous is iodine deficiency, but however, iron deficiency increases the risk of early delivery and the development of iron deficiency in the child within the first few years of life. Alcohol intake. Regular intake of alcohol also increases the risk of fetal alcohol syndrome and fetal alcohol defects, and both of these include impaired mental and physical development. Diabetes, if poorly controlled in early pregnancy, may increase the risk of fetal malformations, excessive infant size at birth, and the development of diabetes in the offspring later in life. Hormonal contraception. These are fertility control products for females, and they include pills, contraceptive implants, patches, and injections. There are about 20 different birth control options, and some of them include abstinence, the birth control sponge, birth control patch, birth control vaginal ring, the birth control pills, birth control shot, Depo-Provera, birth control implant, that is implanon and Nexplanon, female condoms, breastfeeding as a birth control method, this one is natural, the cervical cup or fem cup, outer course, vasectomy, diaphragm, fertility awareness based methods, the pull-out method or the withdrawal, and then the morning after pill or the emergency contraception, the use of the male condom, the spermicide, and sterilization for women. This is tubal sterilization, and also the IUD. So all these methods can be used to control birth and fertility. However, these contraceptives have a lot of effects, and some of the nutritional side effects of this contraception, such as the oral contraceptives, include increased blood levels of high-density lipid cholesterol, and this is the good cholesterol. However, there is also increased blood levels of triglycerides and low-density lipid cholesterol, which is termed as the bad cholesterol due to its stickiness. There is also increased risk of the venous thromboembolism, blood clots, cervical cancer, and cardiovascular disease. And this is attributed to the increased levels of bad cholesterol that sticks along the blood vessels and reduces the area through which blood flows. Decreased blood levels of vitamin B12 and B6, and increased blood levels of copper. That is for oral contraceptions. The contraceptive injections, the Depo-Provera, increases weight gain of about 5.5 kilograms during 1 to 3 years. It also increases blood levels of LDL cholesterol and insulin, and decreases the blood levels of HDL cholesterol, and also decreases bone density. The contraceptive implants increase weight gain, and this causes about a weight gain of 4.1 kilograms after 1 year of implanting. Contraceptive patches are placed on the skin for 3 weeks and then taken off for 1 week. And they also increase blood levels of cholesterol and triglycerides. They also increase the risk of blood clot formation and increase in HDL cholesterol levels. Premenstrual syndrome. This is characterized by life-disrupting physiological and psychological changes that begin in the luteal phase and end with menses. These symptoms occur in about 15 to 25% of menstruating women, and they're usually so bad that a woman who has this premenstrual syndrome may seem to be sick during that time. The common symptoms of PMS include the physical symptoms: fatigue, abnormal bloating, cramps, headache, tender breasts, nausea, body aches. And the psychological symptoms include tension, depression, irritability, mood swings, anxiety, social withdrawal, and anger. We also have what we call premenstrual dysphoric disorder. This is an extreme case of premenstrual syndrome, severe form of premenstrual syndrome, and it is characterized by marked mood swings, depressed moods, irritability, and anxiety. And the physical symptoms include breast tenderness, headache, joint and muscle pains. The possible cause of PMS. The cause is not very clear, but it is thought to be related to abnormal serotonin activity following ovulation. Serotonin is also called the love hormone. So if there is reduced amount of serotonin in the body, you find that this individual or woman is going to have a lot of mood swings and experience series of depression. PMS treatment. A woman who experiences premenstrual syndrome can be given antidepressants containing serotonin uptake inhibitors, which may reduce the premenstrual syndrome and lighten up her mood. Calcium, B6, and chestberry supplements. Calcium should be consumed at a level of 1,200 milligrams per day. Vitamin 6, 50 to 100 milligrams per day, and chestberry, 20 milligrams per day. These have been known to reduce the effects of the PMS. Reduced caffeine intake and supplementation of vitamin D and magnesium are also shown to have limited results, but also a bit effective. Weight status. Obesity and underweight also increase the likelihood of reproductive health problems. Central body fat interferes with reproduction in both women and men. And then weight loss should also be first treatment of choice for obese people, so as to reduce the problem of infertility. Weight reduction methods include focusing on lifestyle changes, reducing the intake of calorie-dense and reduced nutrient foods. And then you have to increase the intake of foods that are rich in various nutrients such as vitamins and minerals. Decrease calorie intake and then increase physical activity levels. Increased physical activity causes shedding off of the excess fat, and then the body will be fit. Weight loss surgery. If efforts fail, bariatric surgery may also help to reduce the central fat. Metabolic syndrome. Cluster of abnormal metabolic and health indicators, and this is diagnosed if 3 or 5 conditions exist. And these conditions include the waist circumference. In men, a waist circumference of over 40, and in women, a waist circumference of greater than 35. Blood triglycerides greater than or equal to 150 milligrams per deciliter, and then HDL cholesterol less than 40 milligrams per DL in men and less than 50 milligrams per DL in women. Blood pressure greater than 130 out of 85 millimeter mercury, and a fasting blood glucose of greater than or equal to 100 milligrams per deciliter. So if 3 of these conditions exist in an individual, then metabolic syndrome can be diagnosed. The consequences of metabolic syndrome are mainly increased risk of cardiovascular diseases and also the increased risk of type 2 diabetes. Therapy can include dietary modifications, weight reduction, and exercise. Bariatric surgery may also be prescribed for patients who are excessively fat, obese, with a lot of central fat. So, pregnancy after bariatric surgery. Fertility may be able to resolve after this surgery. And this surgery, however, increases the risk of some deficiencies. For example, calcium, iron, copper, zinc, thiamine, vitamin B6, vitamin B12, and vitamin D. So it's important that a woman who conceives after bariatric surgery should increase the supplemental forms of these nutrients. So pregnancy is not recommended during the first year after surgery. You have to monitor the nutritional status because of poor nutrient status during the post-surgery weight loss. Hypothalamic amenorrhea. This refers to cessation of menstruation related to changes in hypothalamic signals that maintain ovulation. The functional hypothalamic amenorrhea and weight-related amenorrhea. These are the two types of amenorrhea, and these are caused mainly by deficits in energy and nutrients. Eating disorders and fertility. Anorexia nervosa and bulimia nervosa are also linked to hypothalamic amenorrhea in some women, and it's more likely to cause miscarriages and preterm deliveries, and also may increase the risk of having low birth weight infants. Menses usually resume with weight gain in case of anorexia nervosa. The care involves evidence-based practice that includes the interdisciplinary group of experienced health professionals. The female athletic triad and fertility. This triad basically consists of three conditions coexisting together: amenorrhea, disordered eating, and osteoporosis. And this is triggered when energy intake is over 30% less than the requirement. It results in decrease in luteinizing hormone, follicle-stimulating hormone, and the lack of estrogen. Low hormone levels lead to reduction in bone density. Management of the female athletic triad. Correction of negative energy balance and the correction of eating disorders are proven to be effective, and also vitamin D and calcium supplements to facilitate bone density. Diabetes mellitus. This is characterized by intolerance to carbohydrates with a fasting glucose of over 126 milligrams per deciliter. The types of diabetes mellitus include type 1 that results from destruction of the insulin-producing cells, about 10% of cases. Then the type 2 diabetes, the body is unable to use insulin normally to produce enough insulin, or both, and this is in about 90% of cases. And then the gestational or the onset during pregnancy. This occurs in about 3 to 7% of the cases, and this occurs during pregnancy. It's applied only to women. Diabetes mellitus prior to pregnancy. High blood glucose levels during the first 2 months of pregnancy are very teratogenic and may cause death. And this is associated with a 2 to 3-fold increase in congenital abnormalities in the newborn, and may also cause malformations of the pelvis, the central nervous system, and the heart, which are seen in the newborns, and there are also higher rates of miscarriages in such individuals. Management of type 1 diabetes. Our main goals of management of type 1 diabetes are blood glucose control, the resolution of coexisting health problems, and health maintenance. The diet has to be controlled in the carbohydrate contents, and also the individual has to use insulin in order to control the blood glucose levels, and also physical activity in order to improve the health status. Diet management may be handled in the following ways. The carbohydrate control. Carbohydrates raise the insulin needs more than the proteins and the fats. And the dietary advice must be tailored for every individual. Different individuals react differently to different nutrients, and this brings us to aspects of nutrigenomics. So it's important to understand the body system of an individual before prescribing a diet. Diet choices are also encouraged. Replace simple sugars with reasonable amounts of artificial sweeteners. Choose foods low in glycemic index and high in fiber, especially the soluble fiber. Encourage the brightly colored fruits and vegetables. Lower fat meats and dairy products. Fish, dried beans, nuts and seeds should be increased. The type 2 diabetes may be managed with diet and exercise, and also oral medication to increase insulin production and sensitivity. The preferred management program includes an individualized diet and exercise recommendations, and also weight loss. Prevention of gestational diabetes mellitus. This is considered to be a form of type 2 diabetes, and it is characterized by increased blood glucose levels during pregnancy. How can you control this? By undergoing pre-pregnancy weight loss in case an individual is obese prior to pregnancy. Increase the intake of dietary fiber and also increase exercise. These are able to reduce the risk of developing gestational diabetes. Adhere to healthful diets that are high in fruits and vegetables. Polycystic ovarian syndrome. This occurs in 5 to 10% of women of childbearing age and is the leading cause of female infertility. Many women with polycystic ovarian syndrome are obese or have high levels of intra-abdominal fat. The cause is uncertain. However, it has been linked to insulin resistance, and it appears to have a strong genetic component. Phenylketonuria. This is characterized by elevated blood phenylalanine due to lack of the phenylalanine hydroxylase that breaks down the phenylalanine. And it is a preventable cause of intellectual disability in newborns. Nutritional management for women with PKU includes a diet that is low in phenylalanine for life. The woman has to adhere to this kind of diet for the rest of their life. Celiac disease. Autoimmune disease characterized by chronic inflammation of the small intestine. Inherited sensitivity to gluten in wheat, rye, barley, and this causes malabsorption and the flattening of the intestinal lining. And this is also linked to infertility in some women and men. So basically, these are the various factors that may affect the periconceptional period and the pregnancy outcomes. So it's very important to know your body and control your dietary intake prior to pregnancy, so that at the early onset of pregnancy, you're able to have good results and have healthy pregnancy through term. Thank you.